It's a real pleasure to be here this morning. My job is to sort of stay up in the clouds, not get down in the weeds. However, I've spent my whole life down in the weeds, so getting up in the clouds, I've not been an airline pilot, but I'm certainly willing to try this, so don't blame me if I don't go into too much detail about anything. Neuroendocrine tumors, we think about cells that are dispersed throughout the body, but we also think of the word heterogeneous because these neuroendocrine tumors that are concentrated in certain parts of the body, I'm going to use the intestines for one part, the ones that arise in the terminal ileum act differently than those cells that might arise upstream in the duodenum or in the stomach or downstream in the colon or in the rectum. So it's amazing biology of how is it that cells that have a lot of things in common are so different. Appendix is different from the cells just right next to it in the terminal ileum. So heterogeneous is really the word I want you to be thinking about in this overview talk. We know that most of the neuroendocrine tumors that are seen in the United States, about half arise from the GI tract. So this would imply mostly the duodenum, the jejunum, the ileum, appendix, colon, rectal areas. And remaining ones, about 25-27%, will be in the foregut, more in the lung, thymus, pancreas. And we have a tendency, because the GI tract and the pancreas work so closely together, to call that GEP-NET, so gastroenteropancreatic neuroendocrine tumors. That's an early term that we adopted many years ago, and I really like it because GEP-NET really defines a lot of the biology that we can identify below the diaphragm. One of the things that we know is that the neuroendocrine tumors are increasing over the last 3 or 4 decades. Why is this? Greater awareness, better diagnostic tools, more screening, a number of different reasons. But where are the numbers today? And the NCI publishes data from their own, they have several data sources. Their own site is called SEER, Surveillance, Epidemiology, and End Results, SEER, S-E-E-R. The SEER reporting sites are about, they report about 24% of about all the tumors, all the cancer in the United States is reported into the NCI through these SEER reporting sites, and they're not in every county or every hospital or such. So the SEER, they take the 25%, multiply it by 4, and that's how they get those numbers. The numbers that have just been released by the NCI comes in from the National Cancer Database. Now, this is where the tumor registries in hospitals are recording all the cancers that get diagnosed by pathologists in that hospital. So if you get diagnosed in one hospital, your care is in another hospital, the original hospital that you get diagnosed in reports that to the NCI. So this report just came out in cancer just in the last few months. And this is the group that they highlight is what's happening in pancreas malignancies. Now, if I showed you the whole page, this is a 34-page report. It's got a gazillion tables in it. If I showed you the page just came off of it, you couldn't read it. It's so tiny. So I had to magnify it. The females look the same. So we can see that over this period of time, 18 years, that pancreas cancer has increased to a certain extent. And of that subgroup, we can see that the neuroendocrine tumors now have have steadily increased. Not a lot. This is not what I'd consider a health great catastrophe to kind of figure out what's going on here, but we're seeing a steady increase. And why is that? And I think it's better diagnostic, better awareness and things. When we think about GI NETs, in about half all those patients, the incidence is 2.5 per 100,000. So if you take the 50% that I just told you and then you multiply that by 2.5, that would be in that 5 to 7 per 100,000 in terms of NETs in general. So this most common site is that distal small bowel, usually ileal, and then the rectum being the second one. The overall incidence is similar between the genders, although the neuroendocrine tumors in the stomach, lung, maybe colon, may be a little bit more common in women. African Americans have a slightly higher incidence than other races. Many patients will be asymptomatic for years and are diagnosed incidentally. The annual incidence of lung NETs is around 1 per 3.5 per 100,000. And we classify these as either typical, atypical, and then we get into the neoplasms would include the large cell and the small cell. So most of the lung NETs are centrally located in a lobar bronchi, not in a central lobar or in the periphery, but most of them would be like in that right upper lobe, left upper lobe, in that lobar area. Lung NETs occur more commonly in women, in Caucasians. 58% are symptomatic at the time of presentation, cough, hemoptysis, pneumonia, sometimes chest pain. How we classify this, we'd like to think about where the tumor may start because it tells us a lot about the biology and things that we may need to be aware of in management. In the pancreatic neuroendocrine tumors, we think of these as being non-functional or functional. If they're functional, we think about what hormone may be causing that function. Gastrinoma might be causing some degree of ulcers or bleeding, or insulinomas with blood sugar too low, glucagonomas, blood sugar too high, VIPomas, watery diarrhea, and then somatostatinoma. I find this one to be really interesting because it's mostly in the history. So if I see somebody that's got a neuroendocrine tumor and they've got constipation, gallstones, and then their blood sugars may be up a little bit, I think of somatostatinomas. I diagnosed one of these within the last 6 months. And just by talking to them, I could tell that the somatostatin level was probably not by any other thing. Gallstones and constipation with a neuroendocrine tumor, then things should be thinking about somatostatinomas. You know, when we first discovered these and reported on them in the 1980s, it was really quite exciting to be describing tumors that were making about every hormone that we could look at physiologically. We could find the pathologic variant. And then we turn our attention now to the neuroendocrine tumors that arise in the intestines, and they historically have been called carcinoid tumors. We try to get away from that term. In the lung world, we're not going to get away from it. So a carcinoma of the lung is a grade 1 disease. Atypical carcinoma is going to be grade 2. But in the gut, we try to refer to these as well-differentiated neuroendocrine tumors. And then we'll want to know whether they're grade 1, grade 2, or grade 3. What about unknown primaries? We've talked about pancreas, talked about the gut. What happens when you don't know where a tumor came from, that there's a biopsy in the liver? Do these tumors arise in the liver? Well, not until you've proven they haven't risen somewhere else. So I personally like to do molecular profiling on these tumors, where we take the archival tissue, the tissue that we use. We won't do a special test, but just that biopsy material. If there's enough tissue there, do a cancer type identification with Biotheranostics in San Diego, or cancer type ID with Caris in Dallas or other locations. In 2019, the W Health Organization updated their grading criteria. It's shown here. It's what we use today. We think of neuroendocrine tumors as grades 1, 2, and 3, and then they classify the neuroendocrine carcinomas as small cell type or large cell type or minin. So minin will be a mix. Now the minins, not as much known about those. It could be, just yesterday I had a patient with a distal esophageal minin. It was a high-grade large cell neuroendocrine carcinoma and an adenocarcinoma in a nodule in the distal esophagus. So it's a mixed. It doesn't have to be a tumor. It doesn't have to be a neuroendocrine tumor. It can be neuroendocrine carcinoma with an adenocarcinoma that can be combined. So the minin group now, historically, there's been 15 different names for these type tumors, and the WHO in 2019 have come up with this minin classification. NETs can be non-functional or functional. What do we mean by that? Most of them are non-functional, which means that they may secrete something, but they don't have a syndrome associated with whatever they secrete. So if you secrete chromogranin, there's not really a syndrome that's called a chromogranin syndrome. It's not like carcinoma syndrome per se, but chromogranin is elevated in carcinoma syndrome, but it's not responsible necessarily for the syndrome symptoms. So these tumors can also secrete substances that are simply biologically inactive. I've had patients with gastrin levels 30,000, yet they don't have a single symptom of a gastrinoma, but their gastrin levels are so high. What do? You just stop checking it, basically. I mean, it just drives you nuts. It's meaningless. So you have to put every test you get in perspective and for that person. In the absence of any hormone symptoms may be related to the tumor mass itself. In the functional component, we think of overproduction of hormones, amines, peptides, and those may be associated with those symptoms that are listed here. In the GI carcinoids, under the functional site, you'll see flushing, diarrhea, abdominal pain from the diarrhea, just as cramping, wheezing. More in the bronchial side, more reactivity. We have seen it, certainly have seen it in the intestinal gut side. Hypotension, and then heart disease. Well, heart disease could be a lot of things. Swelling in the legs, shortness of breath, fatigue, dyspneic exertion, and that's we think of as it relates to tricuspid valve problems, stenosis, insufficiency, stenosis of the pulmonic valve, insufficiency of the tricuspid valve. So that's something that comes along with these functional tumors. We have to be thinking about what the end result might be on the body from these, we think serotonin, maybe other components too, attributing to that carcinoid heart. About 10% of people with neuroendocrine tumors will actually have carcinoid syndrome. So that's a small group. And it usually reflects disease in the liver. And this is where we know the cause, hypersecretion of amines, peptides, more or less see it in the midgut. I usually, if it's a pancreas and they've got symptoms that are similar to a midgut carcinoid, I start thinking about other symptoms besides other hormone markers besides serotonin that may be causing it. Gastrin can make people flush, even in VIP, substance P, VIP. Some of these patients may flush as well, and their serotonin levels and things are completely normal. And so what we commonly do when we have the tumors that are secreted by these neuroendocrine tumors, we suppress them with hormonal therapy, somatostatin. How people present, often it's delayed and it's misdiagnosed. You can see if you're in the outer periphery of this wheel, any symptom out there you can come up with could be related to a carcinoid syndrome, but probably not. So you could see if you've got something to the tune of a food allergy. Well, you may have a food allergy, and in addition, you do have a neuroendocrine tumor symptom. So once you get closer into the diagnosis, more symptoms may arise. And then as those symptoms become more severe and become coupled, such as you take diarrhea with weight loss, that's going to get you a CT scan or workup. So eventually you get image, but a lot of times irritable bowel syndrome, even inflammatory bowel disease, misdiagnosis will occur. So I know I touched on this yesterday, but there's a firewall between tumor and cancer. The tumor word is we talk about indolency. On the carcinoma word, we talk about aggressiveness. And we want to get this straight from the pathology. I'd say many people come into my clinic thinking they've got cancer. And then when we get the pathology report out and we see that there's not the word cancer on the pathology report, then they say, well, why I'm confused now. What do I have? Well, you may have a malignant tumor. Why don't you just call it cancer? Well, because some tumors are benign, but all cancers are malignant. So we know the characteristics between the two quite well. We don't want to give chemotherapy to a tumor patient. We don't necessarily want to give hormonal therapy to a neuroendocrine cancer patient. So the hallmarks of neuroendocrine tumors, when we think of the well-developed neuroendocrine tumors arising from the gut, from the lung, these common ones, the somatostatin receptor is present. So these are mostly in the midgut patients that we think, foregut, midgut, hindgut, all three levels of the developed embryo can have it. But the neuroectodermal plate that develops in the embryo gives rise to the catecholamine producing cells. This is the adrenals, the paraganglia, that was discussed yesterday. So we certainly don't want to say that neuroendocrine tumors have to express the somatostatin receptor, because there's a subgroup that develops along a different line like the adrenal gland. So this is just a depiction of when we make the diagnosis of a neuroendocrine tumor. We look at gallium or copper dotatate imaging, looking at the expression of the receptor, localizing, and we can see basically three phenotypes. One would be where most of the disease is localized in the liver. That's the one in the middle. Most of the disease is in the bone. And it's amazingly how asymptomatic somebody can be at that much disease in the bone. And then the combination of we see disease in bone and liver. So this is important on the front end to get it right. You don't want to undertreat or overtreat, since nothing we do is curative short of surgery. If we do get lucky and diagnose a neuroendocrine tumor in its early stages, it's usually incidentally or surreptitious at the time of other surgery, appendicitis or tubal ligation or cholecystectomy. But in the context of metastatic disease, somatostatin analogs become the backbone for management, and then we couple that with potentially using that target later on in management with radiolabeled somatostatin. So local regional therapy can be managed a little differently with local regional treatment, and potentially in addition to systemic as well. Hanahan and Weinberg several decades ago actually published a very nice diagram of all the areas of well, not all, but let's say 10 areas in the cancer cell that go awry. You know, when you start describing cancer, let's describe it at a molecular level. So when we look at the different defects or the different targets that we could look at in the cancer cell, we can see that in those that express the receptor and mechanisms, how things work, or drugs. The FDA certainly requires us to know. You can't just say a drug works. We have to know why it works. So we know somatostatin. We know interferons, even though on this side of the ocean they're not approved for neuroendocrine tumors. But in Europe, interferon became the very first management for carcinoid syndrome. And then mTOR inhibitors. This is the mammalian target of rapamycin. This is where these three agents can sustain the proliferative signal and can block that, because cancer is an autonomous. It continues to grow. It stops it stops the normal signals of cell growth. And then some cells will just refuse to die, just like that guest in your house that never goes home. And we have to encourage them to leave. So the mTOR inhibitors assist that person to be very uncomfortable living there. So with an mTOR inhibitor, nutrients aren't fed into the cells right. They're starved. So that's another way. They don't necessarily obliterate the tumor, very small percent, but we see a lot of the tumors just are stunted growth. And then inducing angiogenesis, the TKIs, the tyrosine kinase inhibitors, Sutent or sunitinib, interferon and mTOR inhibitors can be helpful here. Okay, so we see that we've got a complex disease. We've got multiple things that we can use to treat it. How do we get ourselves together to develop a protocol diagram to be as scientific, as evidence-based medicine as we possibly can? Well, the best way is hold everybody accountable. Hold the pathologist accountable, hold the medical oncologist accountable, the radiologist, nuclear medicine, the surgeon, everybody's held accountable. And that means they have to know what the heck they're doing. So in the multidisciplinary tumor board, you don't get on that tumor board unless you see the disease. If you don't see the disease, and you may be presenting a case, or you may be learning about the disease. But in this, you would come in from one of these three areas, either from the medical side, surgical side, pathology side, radiology, imaging side, interventional radiology, and then we have staffed with our research people as well. So this is strictly for intestinal NETs. The diagram looks different for other NETs. The lung NETs, the pancreas NETs will be a little different, but it's very detailed as it relates to what may go on in those things. So this is everything I do on one slide. I was asked to do this when I left Kenner and left Ochsner in 2011. Dr. Boudreau asked me, will you write down everything you do and put it on one slide? Well, right here it is. So the first thing I do is I want to know how aggressive the tumor is. I want to put that person in one of these quadrants, and sometimes it's difficult, so I might put them right in the middle of it. But is this a low-volume indolent patient, or is this a high-volume aggressive patient? Because the treatment options are going to reflect that. Is this a low-volume indolent patient? Maybe I don't do a whole lot. Maybe nothing. Maybe somatostatin analogs. High-volume aggressive patient, pull the carpet out. Do everything. You just go full guns ahead. So this is really the challenge in getting it right on the front end. If our pathologist gets it wrong, we get it wrong. So we're so dependent upon our pathologists. If our radiologist gets it wrong, we get it wrong. It just compounds the error downstream. So that's when you go and make an assessment in a center like ours or any comprehensive center that sees this. They're going to start over again. They're going to give you a fresh diagnosis, a fresh review, as if it were the time of the initial diagnosis. So what happens after you match up the phenotype and then the treatment? Well, in the world of intestinal neuroendocrine tumors, then we clearly are guided along whether it's grade 1, grade 2, and along that paradigm, what stage, what is the AJCC staging, the American Joint Commission on Cancer. What is that staging? Clinical stage 1 and 2, resectable, surgery, surveillance. Clinical stages 3 and 4, locally advanced or spread. If they're asymptomatic, maybe just still do nothing is an option. Surveillance scanning, establish tumor growth rate. Locally symptomatic, resection of the primary, may use the somatostatin congeners or the analogs, and then go on to local regional therapy, everolimus, CAPE-10, PRT in clinical trials. And then if it's clinically significant tumor burden, progressive disease, then go straight into somatostatin analogs, don't wait. Now for the grade 3 disease, this is where it gets a little bit more complicated. Here is where the cytotoxic chemotherapy may be important, and those different ones vary. Okay, so let's take someone who's functional, yes or no. If they're functional, straight onto the somatostatin analogs. This implies that it's metastatic disease somewhere. And then the question is it working or not? Just because it works in 90%, maybe that in the 10% doesn't work. Well, what happens there? Well, maybe it works only partially. Well, where's the disease dominant? Is it in the liver? Is it extrahepatic? If it's liver-directed therapy is indicated to have better control of symptoms, then maybe low bulk, intermediate bulk, high bulk, et cetera. In the functional case, that's no symptoms, no carcinoma syndrome, for instance. Then either yes, you would go with that if it's a mixed intrahepatic, extrahepatic, would be options of going on to direct treatment. If it's extrahepatic dominant, then systemic therapy, plus that may go on to somatostatin analogs, radiopharmaceutical therapy, et cetera. But if it's not symptomatic, maybe observation becomes an option. Okay, so we know that NETs are heterogeneous. The incidence is increasing. They're classified according to primary site, grade, functional status, and stage. The diagnosis is frequently delayed and it's misdiagnosed. The imaging is anatomic plus functional. That means we do CT scans, MRI scans, and the dotatate scans. The management is multidisciplinary. Somatostatin analogs perform the basis for the management of metastatic disease. Treatment has to be individualizing. This is a quote that you can attribute to me because I just made it up this morning. It's no two patients are alike, no two treatment pathways are alike. Now, I've seen it like that, but not exactly termed just like that. So I'm going to copyright that and put it in front of the FDA. Future is bright. The challenges in the absence of a cure. Now, we're all after the cure. Then we have to focus on increasing quality of life. PRT certainly does that. And survivals will follow. Next generation PRT is coming. That's getting into the weeds. I'm up here, remember, up in the clouds. Combinatorial approaches, we're doing that now, again, down in the weeds. And then the chimeric antigen. I think this is the holy grail. We're starting to do this in medicine. And I just want to end on just creating and telling you there's hope. This is somebody I saw in 2017. We just featured her in our local newspaper. And our president of University, Capilouto, did a shout out to this patient during the last homecoming celebration. So this woman, she's given us her name, Robin Bullock. You can Google her. She's famous now, I guess. This was the CT scan that she came to my clinic with on May the 27th, 2017. I have kind of a fun time. I engage all my people that work with me into it. So I'll look at a scan like this and get my nurse instantly engaged. So I want my nurse to read the scan. And I'll say, do you see something wrong here? So if it passes the nurse scan, then we know that there's something here. Well, the radiologist actually put down that there was diffuse, numerous, hypodense, peripherally enhancing lesions. You can see a few of them. I put red arrows to them. But that's what neurotumors look like on a CT scan. This is the venous phase of the scan. And so it's May 27, 2017. So this is just this past July. Unremarkable liver. She's off all therapy, been off all treatment now for a year. She's traveling the world. She really didn't think she'd be living through her wedding anniversary specifically. So you can Google her, you can read her whole story. It's a lot of pages, a big story. She'd love to become, I'm sure she might love to become more active in NCAN. I know she's traveling to New York a number of times. She's really loves that. So it's a real pleasure to talk to you all about the overview of neurotumors, and we'll be around for a little while to answer any questions.